Well, lovely to see you all. I'm David Sines and I'm the Executive Chair and the Registrar of the Joint Council for Cosmetic Practitioners. So Scotland really jumped ahead of the game and published their response to their consultation on non-surgical treatments. Now, that was really an exciting point in time because although we knew an announcement was imminent, we weren't quite expecting it as quickly. The Scottish Government consulted on non-surgical treatments for Scotland. Remember, this is for Scotland only. It's a Scottish Government initiative and it doesn't have direct relevance to any of the other 3 UK countries. So, they consulted last December. They've now formed their proposals. They propose to translate their proposals into a first reading in the Scottish Parliament as a bill in the autumn session of this year's parliamentary process, with the aim of introducing legislation, or at least confirming the introduction of legislation, by April 2026. And that's quite a fast timeline. So, we're going to assume that the proposals from Scotland will translate into the first reading of the bill. There may be some amendments, but it's pretty solid, I think, in what's being said. First of all, there will continue to be a categorisation of procedures on the basis of proportionate risk. And that's something we've adopted in England in principle. So we have not a green, red or amber category in Scotland as we have in England, but we have 3 groups: Group 1, Group 2 and Group 3. Group 1 procedures are those with lesser risk, such as microneedling and some of the minor or less intensive laser procedures, radio frequencies there. Now, the proposals there are that there will be a licensing requirement with local authorities, with local government. We then move to Group 2. Now, Group 2 is of significant interest to us. And Group 2 includes the much more familiar procedures that are more invasive. These would be the botulinum toxins, the dermal fillers, those, I hate to use the word medium grade lasers, but I think it's better for members of the public and colleagues to understand what we mean there. And things like hay fever injections are there as well. Now, what Scotland have said is this: they require a proportionate response, and their proportionate response is not to limit who can actually provide those procedures by profession or non-profession, but to state that all persons who perform Group 2 procedures must meet a new minimum training standard yet to be agreed, and that's an important point. We don't know what that will be, but unless they are an appropriate, note that word, regulated healthcare practitioner, they will need to perform those procedures within a Health Improvement Scotland regulated premises. Now, Health Improvement Scotland, for those that don't know, and I shouldn't have to say this, but I will, equates to the CQC for Scotland. So a regulated premises, and the procedures will be regulated by HIS, or Health Improvement Scotland. They won't be licensed, they'll be regulated, meaning registration is required. And here's the other big change, or big proposed change, that unless you are an appropriate professional or recognised as, that means a registered healthcare practitioner, and we're not quite sure which will be included there, by the way. We know that doctors, dentists, nurses and pharmacists, particularly as their prescribers, will be there, but I think there's room for others to be considered. There will need to be a supervisor on site whenever those procedures are actually performed. Now, the reason for that is this, that we know that the knowledge and the competence and experience required, one, to administer technical procedures of that nature for fillers and for toxins, is such that it is only available at the present time in undergraduate healthcare related curricula. We also know that the requirement for complications management really does require clinical judgment and clinical assessment. So they're the kind of main reasons, plus the products and the actual medicines being used also require a prescriber's oversight. But complications management is vital. But it does assume that the person who is actually providing supervision, one, is competent themselves in the procedure, has the qualifications and training required, and is also competent in the management of complications, and confirms that they're satisfied that the practitioner whom they are supervising is also competent. That's really important. That's delegation. And I think sometimes regulated healthcare practitioners fail to appreciate they remain accountable for the whole process if they delegate. And that's true of any profession. It's in our codes of practice across the whole spectrum of regulated healthcare. So that's group 2. Group 3, these are the invasive procedures. We call them RED, of course, in England, but these do include, by virtue of the fact they are now designated as surgical. Now, we're talking here about the BBLs, we're talking about breast, buttock augmentation generally, of course, anything to do with genitalia, anything that introduces an anaesthetic reaction or requirement for pain management of that nature. Also, anything that actually involves blood products and involves intravenous transfusion or use of any cannula. So we're now talking here about PRP. It's interesting. That's gone into the group 3 category. A lot of people have asked that question, but it's there. So look for that one. Anything that's intravenous, such as the vitamin infusions, and of course I mentioned those surgical, and of course the ablative lasers are there, and chemical peels that involve phenol peels, for example, where the pH value is of challenge. And there are many others there. Now, what I haven't seen there is teeth whitening. Now that made you think, well, but it is something that's endemic amongst certain parts of the industry, but that's an issue I think the Scottish Government will review. The General Dental Council are very clear that is the domain of dentists because of the peroxide factor, the bleach factor that's there. So that's one I think. And the other one, I guess I'm trying to be thoughtful on, is where does hair restoration surgery fit? So from Scotland then, we also have an age restriction of 18 for all procedures. And an interesting point, because of the geography on topology of Scotland, for equality impact assessment, the Highlands and Islands present a challenge to on-site direct supervision. Now, there's not suggesting any change to the supervision requirements, but there is a proposal that mobile working can occur. But again, mobile working would be HIS regulated. So I'm happy to concede that because we do not approve, from our perspective, mobile working. But of course, where geographies are such on islands, we must be pragmatic. So we're looking for safeguards that can actually mitigate risk. So that's the kind of all-round proposal that's moving forward, and we expect to see draft legislation moving through now the next 3 months. The concept of supervision is something we've all been deeply interested in terms of interpretation. So we know Scotland have said supervision within the building. What does that mean in practice? Does it mean in the room? Does it mean sitting on Nellie's shoulder? Or does it mean you can literally have confidence in the practitioner and continue your work in the next room, but be available to be called? Well, I genuinely don't think there's going to be a lot more detail on that. I'll tell you my reason. I think it's very much up to the supervising clinician, particularly if they're a prescriber, to make a dynamic assessment of the person to whom they're delegating, and also the patient or person that's being treated. So if the person is being treated presents with any additional significant challenge, then of course it should be line of sight. That's a clinical judgment from the supervisor. I think you'd agree with that. Similarly, if you've got an incredibly competent practitioner, then I think you are accountable as the supervisor to move to another room if that's your decision. If you've got a novice who's actually learning, or you have concerns, but you must also exercise the right to be present at any time should you have concerns. Now, I can't say that's how it will land, but that would be my interpretation. I think the fact we've got somebody in the building who has to account to their regulator for their own oversight, bearing in mind the NMC have made that very clear. And by the way, the Royal Pharmaceutical Society is about to review its actual procedures or advice on aesthetic or cosmetic prescribing, and they are the overall standard setting group for the NMC, the General Pharmaceutical Council, and the Healthcare Professions Council. So you can see this is all coming together. So I think the real trick here is to say the supervisor has got to exercise the clinical judgment, and they would be accountable if there was a problem, if they delegated without being in the room. There is something called the United Kingdom internal market. It means that when we left Brexit, we became obviously an independent state, but we also have devolved governments. So we have to look at the impact of what happens in one UK country on the other three. And that will have to be balanced with any legislation coming from London, Westminster, Cardiff or Belfast. So one thing we've made clear, the one thing which is critical, there must be one standard of transferable education and training across the 4 countries. It would be absolutely crazy to have a different standard in one country. So that's not just for the JCCP, it's in the interest of public safety. So for all practitioners, I know it's a time of challenge and turmoil. It's going to be a big challenge for our beauty sector colleagues, first of all, let's be frank. But it's really important to note that the way the Scottish proposals are written, and in fact we would advocate this too, any person who can demonstrate that they can actually achieve the norm, the standardised education and training standard for the future should be able to perform procedures under supervision. And we've made that point very clearly. The second and most important point, of course, is what about our regulated healthcare practitioners who are at various stages of post-undergraduate experience? Many have got level 7 qualifications. Some of them are plastic surgeons, dermatologists on GMC specialist registers. We've got people going through BCAM accreditation. BAMEN also have a framework of education. We, of course, have regulated qualifications that we've approved from Ofqual and, of course, your own academy here at Harley, which was the first. So we're confident that those persons who've achieved the standards that we've set is a benchmark, just as those who've achieved standards with the General Medical Council through specialist registration or potentially through BCAM, we would argue are in a very good place to demonstrate equivalence or compliance with standards. But until we know what those new standards are or where the gaps are, we can't possibly say they will be automatically assimilated as evidence or proof of meeting a new standard for licensing or regulation. Having been an educationist for many years and seeing multiple changes in standards from the GMC and MC, we constantly evolve. And what we do is always to undertake a gap analysis of where I am currently in my experiential learning post qualification, say you're level 7, and then I think it's a matter of demonstrating where those gaps are and maybe top up modules and potentially a much greater focus on CPD. But I think that gap analysis is really important. The other route could be, one we've advocated, there should be a form of credentialing. So persons who really believe, and why shouldn't they believe, they are ready for their advanced driving test. Does that make sense? They've already got a qualification, shouldn't be able to actually present for a top-up with evidence should that be required. So I also hope there'll be a period of time for colleagues to actually prepare for that transition before legal enforcement occurs. So maybe 2 or 3 years, I can't be sure, but that would be my advice. But be confident, but I would also say be very careful about selecting any provider at the present time unless you're sure or feel confident that you will be able to almost accredit what you've learned against new standards. And we can't be definite, so I must stress that on record. I'm not a regulator, we can't confirm what the government will say. So that whole point, about a universal standard for education and training that I think Scotland will certainly be advocating, because they've actually stated they're going to develop a new standard for education and training. That's in their proposal. That's got to be, in my view, the bedrock or cornerstone of what England actually determine once they actually release their response to their consultation of September 2023. And remember, we're a long way adrift now from that period of time when that consultation came out from England. So I've been advocating, and many colleagues have, for a review of the current education and training standards. JCCP has those. They're not universally applicable, of course not, but they are there on the basis of what Health Education England proposed. I chaired that review for the government, and those standards were overseen by the Department of Health at that time. So they are there. Equally, we have the National Occupational Standards, which are relevant in Scotland, Wales and Northern Ireland, but not mandated in England, which is quite interesting. They more or less align. And we also then have to ask the question, how does all this fit with new standards yet to be developed with Skills England? And there's a new one for you. Skills England is a new organisation that will be setting the standards for apprenticeships. So apprenticeships will definitely be part of a new pathway, and they will go up to level 8. So we are using the correct language with level 7. It's adopted because it means the way in which we assess at that significantly high level of competence and knowledge will be there. I'm quite confident that we will need to review all of the standards that we all have. We'll do that in partnership with the Cosmetic Practice Standards Authority, really important. That's BAPRAS, British Association of Dermatology. JCCP is a sister agency, so we work seamlessly together, and we've already started work in preparation to look at what standards do we want for PRP. And we don't have those at the moment, but have similar conversations potentially about some of the weight loss injections, although my view is that's probably a job for NICE to undertake. But you can see we're already starting our work with a universal standard, but it's all in the absence of England making its final determination. I'm hopeful that we will hear in the not too distant future from England, bearing in mind Scotland have made their decisions now, and I'm hoping they'll align, but please don't expect to see the exact same translation in England in terms of who regulates. England consulted on the basis of local authorities licensing for the amber and green. Scotland consulted on Health Improvement Scotland for Group 2 and 3. So I genuinely don't know what England will say, but I guess it's quite imminent now in terms of hearing from them. And education and training will be at the heart of this because it's the standard for governance, patient safety and assurance, as will insurance be, and of course fit and proper person. And Scotland will expect those uniform standards for whether it be Group 1 licensees or Group 2 or Group 3 regulated practitioners with HIS. What a big challenge we've also had with all of this, because the fallout comes to particularly nurses who are not at the present time legally empowered to hold emergency kits or stock medication in England, Wales or Northern Ireland. Now they are in Scotland, but it's the Medicines Act. Now we know that Act will need to be revised if we're going to be able to implement this supervision or supervisory standards that we advocate at JCCP. So we are very clear from the JCCP's perspective, and we're supporting organisations such as BAME, British Association of Medical Aesthetic Nurses, in actually ensuring that the government seeks to review the Medicines Act to permit nurses to carry emergency stock. Now remember, it's not about just opening up, holding medicines, it's about emergency stock for emergency use in emergency situations. And that's a conversation we're also having and have had and will continue to have with the NMC. I can't possibly advise what they might say, but I can say they understand the situation. Well, there was a question raised, it's actually responded to in the Scottish proposal. Should there be a regulator for unregulated practitioners? And the answer is, as far as I can perceive, it was considered, but it was actually rejected on the basis that one, it would be an unworkable solution at the present time, but the fact that oversight is being provided now, and there will be a requirement for registration with Health Improvement Scotland with oversight for Category 2. Remember, Category 3 procedures are utterly restricted to appropriate regulated healthcare practitioners. So when we come back to Group 1, then they will be licensed, so they'll be accountable to their local authority for their practice. I guess there'll be a register of named licensees from a local authority, but certainly there is not a central register.